Hello. This is the ARD study note. This note is the second part of the supplemental oxygen therapy, which is about the determination and stability of FiO2 in the low-flow system and high-flow system. The low-flow system devices such as the nasal cannula and simple oxygen mask, and the high-flow system devices like the Venturi Mask and Air-entrainment Nebulizer. In the implementation of supplemental oxygen therapy, determining and maintaining stable FiO2 according to the device is an important clinical issue. As explained in Part 1, there are differences between the low-flow system and the high-flow system as follows. The low-flow system is a system where the device supplements part of the patient's peak inspiratory flow with oxygen, and the rest is directly inspired by the patient from the room air. Therefore, the FiO2 supplied to the patient is determined by the mixing ratio of the 100% FiO2 oxygen supplied by the device and the 20% FiO2 room air inspired by the patient. However, while the oxygen flow of the 100% FiO2 supplied by the device is fixed, if the patient is unstable, the self-inspired tidal volume or peak inspiratory flow can vary with each breathing cycle depending on the respiration pattern. As a result, a variable air dilution effect has happened with each patient's breathing cycle, and ultimately, a variable FiO2 is supplied. On the other hand, the high-flow system is a system where the device provides a flow rate much higher than the patient's peak inspiratory flow, regardless of the patient's respiratory pattern and without the air dilution effect. A fixed FiO2 determined by the device is supplied to the patients. For these reasons, the low-flow system is often referred to as a variable performance system, and the high-flow system is referred to as a fixed performance system. Now, let's take a look at representative devices of each system. Representative devices of the low-flow system include the nasal oxygen catheter, nasal cannula, and simple oxygen mask. Among these, the nasal cannula and simple oxygen mask are the most commonly used in clinical practice. Here is a question. When we supply oxygen at a rate of 10 liters per minute to a patient who is in stable breathing using a nasal cannula, the FiO2 is approximately 60%. There is principal rule of 4. This rule states that in a patient who is breathing steadily, each liter per minute of oxygen delivered via a nasal cannula will increase the FiO2 by about 4%. Therefore, at 2 liters per minute, the FiO2 is formed by adding 20% room air FiO2 to 2 times 4%, resulting in 28% FiO2. So, for an oxygen flow rate of 10 liters per minute, you would calculate the FiO2 by adding 20% room air FiO2 to 10 times 4%, yielding 60% FiO2. Is it correct? The nasal cannula delivers an oxygen flow of up to 6 liters per minute in adults, and less than 2 liters per minute in infants. As a low-flow system, the stability of the FiO2 can be variable. It can be used in all age groups, is easy to use, and is disposable. It's inexpensive and comfortable for patients. However, it can be easily dislodged from the nose, can be uncomfortable at high flows, and may cause nasal dryness or bleeding. If there are polyps or septal deviations, the flow could be blocked. Therefore, it's suitable for stable patients who require a low FiO2, or for home care patients requiring long-term therapy. When breathing at a normal rate and depth, according to the rule of 4 principle, the FiO2 increases by about 4% for each increase of 1 liter per minute in oxygen flow. However, it's important to note that this principle only applies up to an oxygen flow of 6 liters per minute. In other words, even if you increase the oxygen flow further, the FiO2 cannot exceed 44% or 45%. Therefore, this question is not accurate. If a patient is supplied oxygen at 10 liters per minute with a nasal cannula, this is incorrect. although the oxygen saturation might not have increased, prompting an increase in oxygen flow. In such a case, medical practitioners should not increase the flow further, but should consider change to different devices. A simple oxygen mask can deliver a flow of 5 to 8 liters per minute, and in some cases, up to 12 liters per minute. Like the nasal cannula, it's a low-flow system, so the stability of the FiO2 can be variable. Its advantages are similar to those of the nasal cannula, but its downsides are that it can be uncomfortable for patients, must be removed when eating, and can interfere with heat loss in febrile patients. If an unconscious patient wearing the mask vomits, it can create serious complications. Therefore, it's a suitable device for emergency situations or short-term therapy where moderate FiO2 is needed. In patients breathing at a normal rate and depth, the simple oxygen mask can provide 40 to 60% of FiO2 at a flow rate of 5 to 8 liters per minute. However, it's important to note that, at flow rates below 5 liters per minute, there's a risk of the patient rebreathing some of their own exhaled CO2. Specifically, when a patient exhales, the CO2 they have breathed out remains inside the mask. If oxygen is supplied at a quick flow of about 5 to 6 liters per minute, the swift flow will wash out all the pooled CO2, allowing the patient to inhale only fresh oxygen and room air in the next inspiration. However, if oxygen is supplied at a lower flow in the same situation, there may not be enough washout, leaving some CO2 remaining. In the next inspiration, rebreathing of CO2 occurs. While this may not be an issue in patients with normal respiratory drive, in those with reduced respiratory drive or pre-existing CO2 retention, there's a risk of CO2 narcosis or respiratory failure. If a patient, like the one in this case, is receiving oxygen at 2 liters per minute through a simple oxygen mask, there is a risk of rebreathing CO2. Even without looking at the oxygen gauge, there is an indicator that can inform us if the oxygen flow is insufficient. Specifically, if there is fog inside the mask, it signifies that the oxygen flow is not adequate. Next are the high-flow system devices. These include the Air-entrainment or jet-mixing Venturi Mask, Air-entrainment Nebulizer, and the high-flow nasal cannula. Recently, the frequency of Venturi Mask usage has been quite low, with the Air-entrainment Nebulizer seeing a slightly higher use. As many of you know, the use of the high-flow nasal cannula has been rapidly increasing. Despite their low usage, understanding the mechanism and limitations of the Venturi Mask and the Air-entrainment Nebulizer is important in a clinical setting. The basic mechanism of the Venturi Mask and Air-entrainment Nebulizer is the Air-entrainment or jet mixing system. This utilizes the Bernoulli principle and constant jet mixing. The Bernoulli principle states that as the velocity of a liquid or gas increases, the pressure around it decreases. Thus, as a liquid or gas passes through a narrow space and its velocity increases, the pressure decreases. Constant jet mixing refers to the phenomenon where, when a liquid or gas is injected at a high flow, turbulence forms causing the surrounding liquid or gas to mix. Therefore, in a structure like this, through a tapered nozzle, if oxygen is supplied as a jet flow, the surrounding pressure decreases below atmospheric pressure and a shearing force arises. Room air is then entrained through the ports and mixes with the oxygen, resulting in a total mixed gas supplied to the patient. Here, the larger the size of the port or the smaller the size of the jet nozzle leading to a faster flow, the greater the total mixed gas flow. Venturi Mask is a device composed of a jet nozzle, entrainment ports, and a mask, and is designed to work based on these principles. It typically provides a total gas flow of over 40 liters per minute. This eliminates the risk of CO2 rebreathing that can occur with a simple oxygen mask. The FiO2 is determined by adjusting the mixing ratio of the supplied oxygen and room air, which can be done by changing the size of the entrainment ports, or replacing the nozzle with a different size. Therefore, the amount of oxygen supplied, the amount of room air entrained, and the total gas flow are all closely related. To achieve the said FiO2 correctly, a minimum recommended oxygen flow is crucial. In a Venturi mask, to achieve 24 to 26% FiO2, a minimum of 3 liters per minute of oxygen flow is required. For 28 to 30%, 6 liters per minute is needed. For 35, 40 and 50%, 9, 12 and 15 liters per minute of oxygen flow are needed, respectively. At these settings, the total gas flow delivered to the patient ranges from 79 to 41 liters per minute. In the case of this patient, the entrainment port setting on the Venturi mask is for a FiO2 of 45%. But if the oxygen flow supplied is 3 liters per minute, the FiO2 of 45% can never be achieved, because the minimum recommended oxygen flow is far too low. These conditions may vary with manufacturer. Therefore, it's crucial to consult the data sheet of the specific manufacturer when using a Venturi mask. The Air-entrainment nebulizer is a device that combines humidification and temperature control functions with a Venturi mask. Just like the Venturi mask, oxygen is supplied as a jet flow through the nozzle on top of the adapter, which reduces the surrounding pressure and allows room air to be entrained. Furthermore, as the pressure around the adapter's entrainment port decreases below atmospheric pressure, water rises from the bottle below and is nebulized. This process results in humidified and oxygenated mixed gas being supplied to the patient, facilitating breathing and sputum expectoration. In an air-entrainment nebulizer, the FiO2 setting at the entrainment port, the minimum recommended oxygen flow, and the total gas flow are also closely related. Therefore, it's important to refer to the provided data sheet. An important limitation of the Venturi mask and air-entrainment nebulizer, which utilize the Bernoulli principle and constant jet mixing, is that, as the FiO2 increases, the total gas flow decreases, inversely proportionally. For instance, with the Venturi mask we discussed earlier, as the FiO2 setting increases, the total gas flow determined at the minimum recommended oxygen flow for each setting decreases, step by step. Specifically, at an FiO2 of 50% with an oxygen flow of 15 liters per minute, the total gas flow decreases to 41 liters per minute. The total gas flow for the commonly used air-entrainment nebulizer, the Kendall-Respiflow-Mn, is determined by the following equation. The same phenomenon occurs here as well. Whereas the FiO2 increases, the total gas flow decreases. However, a bigger problem arises when the FiO2 is at 40% with an oxygen flow of 8 liters per minute. The total gas flow decreases to less than 40 liters per minute, thus losing its function as a high-flow system. This limitation is a significant issue in the clinical use of Venturi masks and air-entrainment nebulizers. There was no adequate solution until the advent of the high-flow nasal cannula. This is the second part of our supplemental oxygen therapy, which covered FiO2 determination and stability in low and high flow systems. Low flow system devices such as nasal cannula and simple oxygen mask, and high flow system devices such as Venturi mask and air-entrainment nebulizer. Thanks for your listening.